Ma'am, can I share the slides from my end?
Yeah, you can do that, Shweta.
Okay.
That should be okay.
Kiran sir, can you please confirm if the screen is visible?
Yes, screen is visible.
Okay. We are waiting for Puri sir from NACO to join us. Kindly bear with us. Snehalata ma'am, can you please confirm if Puri sir is with you? Snehalata ma'am, can you please unmute and confirm if Puri sir has joined? Sorry for the delay. Participants are requested to kindly bear with us. Snehalata ma'am, please confirm if Puri sir has joined. Yeah, he has joined. Please give me 2 minutes.
तो लिखा है म्यूट
Yes, sir.
ऑडियो और
So you're audible.
now I am audible.
Yes, sir. Yes. Thank you, sir.
Yeah.
Kiran sir, can we start the recording, please? Good afternoon, everyone. iTech India welcomes all the participants for today's National Distance Learning Seminar Series. We are disseminating the national guidelines for HIV care and treatment 2021. Today's topic is management of ARV toxicities, and the speaker are Dr. A.K. Puri sir from NACO, Dr. Priya Patil ma'am from COE JJH, and Dr. Reshu Agarwal ma'am from CDC India. I now request Puri sir to please give the opening remarks.
So, good afternoon, all the participants. First of all, I'm very thankful to all of you for joining this meeting from your busy schedule. Everybody, to the speakers, to those who are joining from other ART centers, all the counselors, all the medical officers, and because these topics are very important, and this is really will enhance your knowledge. So in this topic, we are right now we are having two eminent speakers, Dr. Priya Patil and Dr. Reshu Agarwal. So we will be talking about the about the first line ART in the adults and the adolescents. and, and management and ARV toxicities. So, as you know that the drugs, the first line drugs are tenofovir, zidovudine, lamivudine, abacavir, and recently it has dolutegravir has been added during 2020. So after introduction of DTG, the majority of the patients are now on TLD. So as a result of that, now we have to concentrate our toxicity, on these three drugs, whatever toxicity is happening. Although few of the regimes are still going on, wherever those drugs, there are certain PLHIV, those who are still continuing, and we cannot still transit to them to the new TLD. So, but in the course of time, we are planning to put them on TLD only. So it is very important to understand the toxicity of the drugs and various and the clinical signs and symptoms associated with the toxins, toxicities. So this will help to understand, to manage you the ARV toxicity. If you will be knowing about the signs and symptoms regarding the toxicities. So now I hand it over to our speakers, Dr. Priya Patil and Reshu Agarwal. They will take you forward for further. Thank you. Thank you.
Thank you so much, sir. We'll quickly
Thank you,
run
sir.
through the pre-test. Kiran sir, can we have the pre-test, please? Thank you. Participants are requested to please attempt the pre-test questions. There are 5 questions in all. The first 4 questions have single choice answer. The 5th question is a multiple choice question. Please scroll your screen and attempt all the 5 questions. We have 2 minutes for the pre-test. Participants are requested to please start attempting the pre-test. Only 11% of the participants have attempted so far. We would like to have it at least 50% participation. Kiran sir, we can end the e-poll now. I now request Reshu ma'am to kindly continue the session.
Thank you, Shweta, and thanks so much, Dr. Puri, sir. So for today's session, we are going to discuss about the management related to the ARV toxicities. In this session, we would talk about the introduction, where we will discuss the major toxicities pertaining to the ARV drugs. Then in detail, we will discuss about the DTG toxicity as well as the tenofovir toxicities, because these are the two main drugs which are being used in the program currently. Then we will also try to learn about the grading of the toxicities, management of the toxicities in terms of drug substitution if required, and then specific guidance around impaired renal function. Next, please. Yes. So talking about the ARV toxicities, why do we really need to bother about the ARV toxicities? Obviously, like, we are really doing good in the program. Our patients are tolerating most of the ARVs well. So why is there a need to discuss about the ARV toxicities? So one is, like, from the patient's perspective, it is very important because if the patients are not tolerating the drugs well, then the chances of their retention or their adherence to the ARVs are compromised. So it's very important that we ensure a timely remedial actions for the patients who have any sort of drug toxicity. Then from the provider's perspective also, it is very important, because otherwise providers will not have confidence in prescribing the drugs. So it is very important to understand the toxicity profile of each of the drugs, so that the providers who are working at the ART centers, they are confident when they are prescribing and giving the drugs to the patients. Thirdly, from program perspective, it is very important to have proper information collected on the toxicities which are being reported at the ART centers, and also their grading and the actions taken, so that program can actually take a call in terms of whether using that regimen is, like, appropriate for the program or not, or some changes are required, or if any remedial actions are to be put into the guidelines, they can be suggested. So it is very important that at the ART centers, we keep an eye on the toxicities which are generally produced by the ARV drugs. So same slide, Shweta, previous one. So these toxicities could range from low-grade toxicities, which would, like, sort of cause a very limited intolerance or interference with the patient's life, or they could be really very serious, like, not allowing patient to perform day-to-day functioning, or maybe even life-threatening. So it depends on the type or the severity of the toxicity, and accordingly the actions have to be taken, which we will be, like, discussing in the subsequent slides. then like when we are talking about the toxicities, it is very important to understand that every time it's not only the ARV drugs which could have led to that adverse event. So at times it could be the complications related to HIV. The patient, could be like coming with the advanced disease, or maybe having some other symptoms which are like related to HIV, and these symptoms could be like sort of labeled as ARV toxicity. So it is very important to differentiate these. Secondly, it could be a new OI which could have like come to the surface after provision of the ARV drugs. It could be iris. Then the other things would be the comorbid conditions or the concomitant medication. So some of the symptoms because of the comorbid conditions, or maybe the other drugs might be the culprit and might have caused some discomfort to the patient, and we might think like these could be related to ARV. So whenever like patients report of any adverse event after starting the ART, it is very important to differentiate between like the other causes, and before we label that as the ARV toxicity. And also this would also be helpful in taking appropriate action in terms of providing comfort to the patient. Next slide, please. So generally, like classifying the ARV toxicity, so usually like what we use in the program is different classes of drugs. So when it comes to NRTIs, usually what we have is the mitochondrial toxicities, which is usually depicted in the form of lactic acidosis, pancreatitis, lipodystrophy, hepatic steatosis, peripheral neuropathy, anemia, or myopathy. And the NRTIs which we use in the program currently are basically zidovudine, lamivudine, and abacavir. Then coming to NTRTI, we use tenofovir, and it is usually associated with nephrotoxicity. Then integrase inhibitors, and currently we are using DTG in the program, and we will talk about the toxicity profile of DTG in subsequent slides, but it has been supposed to be like linked with weight gain, hepatotoxicity, and allergic reactions. Then NNRTIs, and the now like I think program is like phasing out the NNRTIs. Efavirenz and nevirapine are being phased out, but the usual drug toxicities related to these drugs are skin rash, hepatitis, or the CNS toxicities. Next, please. Discussing the adverse drug effects of NRTIs in detail. So tenofovir is usually associated with renal toxicity and bone demineralization. Zidovudine usually with anemia, neutropenia, and bone marrow suppression, and there could be other associated symptoms also. Then lamivudine, it has very minimal toxicity and usually rash, which is like very rarely seen, but if it is seen, it is really severe. And then abacavir toxicity, which is in the form of hypersensitivity reactions, and usually 3 to 5% of the patients might report hypersensitivity reaction, which can be really fatal. So it is very important to take timely action in terms if whenever like there is any risk or any symptoms reported to hypersensitivity reactions pertaining to abacavir hypersensitivity. Next, please. Efavirenz is usually associated with the central nervous system symptoms, dizziness, insomnia, confusion, hallucinations, agitation, etc. And we also last time when the study was done by NACO, it was depicted that because of the CNS symptoms, a lot of patients were not actually adhering to the treatment, and it was one of the very important reasons for LFU rates and poor adherence rates. Again, nevirapine, which is being phased out from the program now, but the usual symptoms with nevirapine are hepatitis, sometimes life-threatening hepatotoxicity, skin rash, and occasionally progressing to the severe conditions. And you could even have SJS or 10 with nevirapine. Next, please. With atazanavir and ritonavir, what we see is the electrocardiographic abnormalities, which are quite common, especially the QR prolongation. Then there is increased bilirubin levels, which are usually clinical, clinical and benign. So there is no need to get panicky about it or change the regimen unless patient is really very stigmatized. And when you compare atazanavir with lopinavir, comparatively, the lipid problems are less associated with atazanavir as compared to lopinavir. Coming to lopinavir, ritonavir, so the common symptoms are usually diarrhea, nausea, vomiting, abnormal lipid profile, which is a very common symptom associated with lopinavir ritonavir, and then the glucose intolerance. Next, please. Coming to integrase inhibitors, then and what we are using in the program is basically dolutegravir, and this common side effect, because it's comparatively a new drug, and the toxicity profile of this drug is not very well developed, and in most of the patients it is very well tolerated, but it has been reported to be associated with hepatotoxicity, some weight gain in combination with other ARV drugs, allergic reactions, and insomnia. Then deltagravir is associated with hepatotoxicity, allergic reactions, myalgia, myopathy, and skin rashes. Next, please. So if we try to understand in terms of the medium, short-term, medium-term, and long-term toxicity of the ARV drugs, so usually with zidovudine, usually the short-term toxicity would be like headache, nausea, vomiting, and bone marrow suppression and anemia. And usually, like as the treatment on zidovudine is prolonged, you would see more cases of anemia as a mid-term toxicity. For lamivudine, the short-term toxicity is skin rash, and usually if it is tolerated well, then we don't see any side effects in long-term. Abacavir is again associated with the short-term toxicity, which is in the form of hypersensitivity. Next, please. With DTG, the short-term toxicities are basically nausea, diarrhea, insomnia, skin rash, or hepatotoxicity, and most of these are self-limiting. And in terms of long-term toxicity, as I said, this is a new drug, so the toxicity profile of this drug is not very well established, and as of now, we don't have any documented long-term toxicities. Coming to efavirenz, the short-term toxicities are drowsiness, dizziness, confusion, and other CNS symptoms and skin rash, and there are no mid-term or long-term toxicities associated with this drug. And similarly with navidapine, it is skin rash and hepatotoxicity with no documented mid-term or long-term toxicities. Next, please. Now, as I was discussing earlier, like we might have like overlapping reasons for the toxicity. So usually, like when the patients are complaining of bone marrow suppression, so it's not always that the ARV is responsible. We have to see for the other concomitant medications also, and there are other drugs which might cause the similar symptoms like zidovudine or CPT, Depson, or some treatment for the OIs. Similarly, for hepatotoxicity, usually like most of the ARV drugs are associated with hepatotoxicity, but then otherwise also like when the patient is on IPT or even on ATT or fluconazole or CPT, so those are the other culprits and which needs to be kept in mind when we are dealing with the patients who are complaining of hepatotoxicity after initiation of ARVs. Similarly, for peripheral neuropathy, usually stavudine and stavudine is anyways not used in the program anymore, and then isoniazid or IPT is also associated with it. With pancreatitis, it could be even CPT which is given to the patients, and especially all the patients who are newly initiated on ART. Next, please. So coming to the dolutegravir adverse effects. So talking about DTG, as Dr. Puri sir already mentioned, that this is the most common ARV drug, like being used in combination with other ARVs under the national program. So it is part of our first line ARVs, it is part of our second line ARVs, it is also part of our third line ART regimen. So this like most of our patients, I think currently to the tune of 90% of our patients are on DTG based regimen. Shweta, can you make it on the presentation mode here? Thank you. Right. And overall, DTG is supposed to have a very good safety profile. There are the studies have shown that the toxic effects or the adverse effects of this drug are comparatively very low, very few metabolic side effects. And there are some minor side effects like insomnia or GI intolerance or skin rashes, which are usually reported in the initial phase and do not require any change of drugs. And they are usually self-limiting, or you can just for insomnia, if the patient is taking drug at night, you can advise the patient to take the drug in morning, and usually these symptoms they get contained. The other concerns which have been raised with DTG, and I am very intentionally using the word concern because these are not the adverse effect which have been established for DTG. So there may be some concerns or potential risk, but they are not necessarily the adverse effects of DTG. So people usually talk about the neural tube defects in fetus when the pregnant lady is using DTG at the time of conception. And also there are concerns regarding the weight gain. So we will discuss about these two issues in more details in the subsequent slides. Reporting on serious adverse events of hyperglycemia or diabetes is also like being one of the concerns, but then again, the studies are very limited in context to DTG, especially from the programmatic settings. And NACO has actually commissioned a very big multicentric study at 60 ART centers where the data is being collected and being analyzed by NACO. And we are trying to understand how the patients in the Indian context are responding to DTG. So hopefully that data would be like, from Indian context would be available very soon. Next slide. So, yeah, so this is the data from one of the very large study from the program settings from Brazil, where like 72,000 patients were followed for 1 year. And there, what they found was like 2.24% of the patients reported adverse effects. And of these 2.24%, and the common adverse effects were nausea, diarrhea, headache, dizziness, and insomnia. And of these 2.24% patients, 88% of the patients did not have had any serious adverse effects. Most of these adverse effects were self-limiting. And most of the patients did not require any hospitalization or change of the regimen. Even the study which is being commissioned, which has been commissioned by NACO, in the same in that study also, what NACO is finding is like the adverse effects are to the tune of 1 to 1.5% only, which is really very low, and it is very reassuring that the adverse effects of DTG in the Indian population are very low, and the adverse effects or the symptoms which we are getting are almost similar, like skin rash, nausea, headache, dizziness, insomnia. So these are some of the common symptoms which are being reported in the Indian population also. So we will wait for more data from the Indian study, but for now, like whatever preliminary results are available, it seems to be very reassuring. Next, please. Coming to the DTG and neural tube defects. So as per the latest WHO guidelines, the potential risk of neural tube defects associated with DTG has come down significantly. It's because, I mean, over the time, more and more data from CIPAMO study and other studies is available. And as per the CIPAMO study, the defect is found to be to the tune of less than 0.2% only. And now this percentage is actually comparable with non-DTG based ART. So statistically, between DTG and non-DTG ARV regimen, there is not much difference. And WHO is now actually recommending a women-centered rights approach, and so that women are also benefited by the good effects or by the positive benefits of DTG-based regimen. So usually what is said, like the women should be given an informed choice. They should be explained about the overall benefits of DTG and the slight risk which might be associated with the neural tube defect, and they should be guided and supported in taking an informed decision. Next, please. And so if a woman is planning to become pregnant, so these women should be counseled about the benefits of DTG and explained about slight risk, as I said. And if these women are ready to take DTG, then they should be prescribed DTG. But in case if despite of proper counseling and giving proper information on the overall benefits of DTG, even then if the women is not willing to take DTG based regimen, then only in those cases alternative options should be explored. But otherwise, as far as possible, DTG women should be provided ample guidance and counseling for use of DTG. So the women who are already on DTG-based regimen, and if they become pregnant, they should be asked to continue DTG-based regimen and should be adequately counseled. Any newly diagnosed women who is coming to the ART center as a new patient, so they should be started on DTG-based regimen irrespective of the duration of pregnancy when they are reporting. And if any woman who is pregnant and not on DTG-based regimen, they should be shifted to DTG-based regimen. So this is as per the national guidelines now. Next, please. Coming to the issues regarding the weight gain and DTG. So DTG, I mean, the studies have shown that when DTG is used with TAF, then the chances of weight gain are comparatively high. But when we are using it with tenofovir, we actually don't see that much of rise in the weight gain. And obviously on this issue, more information or more data is awaited. Usually what is seen that the weight gain is usually dependent on the gender or the ethnicities, because especially like a higher weight gain was seen in the African population, especially in women. Also, the lower CD4 counts and high HIV RNA, which are sort of indicative of the advanced HIV disease. So that means if the patient is already like deteriorated and is having poor BMI to begin with, poor weight to begin with, in those cases, I think it might be a positive effect of the DTG that these patients are showing a positive response once they are put on DTG, and weight gain in such cases could be a positive response. So, I mean, any observation in terms of weight gain should not be taken as a negative thing. It should be like further seen and evaluated. And again, as I said, that NACO in its study is also like looking at the weight gain trends also. And even again, like the initial results from that study are again very encouraging, that NACO is not seeing a very massive or significant weight gain. And usually the patients who had a poor BMI or poor CD4 count at the baseline are having a higher weight gain or changing their BMI levels. So which is again a positive thing. Yes, next, please. Then there have been some concerns which have been raised by some of the practitioners, some of the ART centers regarding the DTG use and the renal impairment. So DTG can cause tubular secretion through the inhibition of the OCT2 mechanism, which is which is usually noticeable, marked, but it is non-pathological and non-progressive with no risk of renal toxicity. So usually you will see a mild change because the tubular secretion diminishes. So there is more retention of serum creatinine in the body, but there is no risk of renal toxicity, and you see a slight marked increase, which is non-pathological and non-progressive over the time. So one should not be really like get apprehensions about the renal impairment with DTG. And usually, like when you get such cases, it is important to see the trend of the serum creatinine levels, and also it has to be supported by the urine protein, which would be a good marker along with serum creatinine. So just like don't label any increase in the serum creatinine as like renal toxicity. Then for the patients who are already an established case of renal insufficiency, no dosage adjustment for DTG is advised, except on the days of dialysis, where dosage has to be taken post dialysis. So this is the only thing which one has to remember. Next, please. Coming to the hepatic insufficiency, so no dose adjustment of DTG is needed with hepatic insufficiency, and no dose adjustment is required for DTG in cases of Child-Pugh A or B scores, but it is contraindicated if the Child-Pugh score is C. Next, please. So the important points one should consider while prescribing DTG. So adequate counseling on lifestyle and dietary changes is very important. So whenever you are prescribing DTG to your patients, please do inform them about the about nutritional diet, good diet, and also the changes in the lifestyle and the need for the physical exercise. It could be walking, it could be yoga, it could be aerobics, anything. But then as per the WHO recommendations, all PLHIV should undergo at least half an hour to 1 hour exercise, physical exercise every day. Then measurement of blood pressure for hypertension is very important. It is also important to monitor the metabolic complications, especially the glucose and lipid profile. So as per the revised guidelines at baseline, glucose levels and preferably, if possible, fasting blood glucose should be done for all patients initiated on DDT-based ART. And then weight monitoring needs to be done for all the patients. Next, please. Over to Dr. Priya, ma'am.
Thank you, Dr. Reshu. And I would like to thank ITEC and NACO for giving me this opportunity. And I would like to thank Dr. A.K. Puri, sir, for his opening remarks. So taking forward from where Dr. Reshu left. So as we said, TLD is the first line regimen now. And so we are mainly focusing on the toxicities of dolutegravir and tenofovir. So now coming to tenofovir toxicity. So basically tenofovir is a commonly used ART drug, which has a relatively long half-life. It has a good overall safety profile with fewer metabolic side effects and mitochondrial toxicities. So the major side effects of tenofovir are renal toxicity. Now, though the incidence of renal toxicity, if we see in the literature, there is a range mentioning from 3 to 5%. And some of the studies show a higher incidence and some have lower incidence. But the main thing about renal toxicity of tenofovir is that we should be aware and alert about this toxicity, because if we are not able to pick it up in time, then the patient can progress to irreversible nephrotoxicity. So that is very important. So we are going to discuss in details regarding the presentation and the manifestation of renal toxicity because of tenofovir. Also, because of tenofovir, there can be a decrease in bone mineral density and there is a bone toxicity. So we are going to focus on these two side effects. So next slide, please. Okay, so coming to the nephrotoxicity. So tenofovir can lead to renal impairment, which is characterized by increase in the serum creatinine with or without proteinuria. So there are different patterns of kidney injury. So they include, so one of the presentation is acute kidney injury due to acute tubular necrosis. So how does the patient present when the patient has AKI? Generally, the timing of the AKI can be within the first month after starting tenofovir, or it can be any time, even after 1 year or any time when the patient is on tenofovir, you can see AKI. So the general presentation is that the patient commonly presents with nausea and vomiting. So it is because of uremic gastritis. And whenever we have a patient who has severe persistent vomiting, because of whenever he's on this tenofovir based regimen, then we must rule out nephrotoxicity and a prompt serum creatinine should be advised. So patient, we have seen at JJCOE, we have seen this complication, and the creatinine can go as high as 7 or 8 sometimes. And this complication, if promptly it is not recognized, the patient can have other severe uremic complications, including severe acidosis, and patient can have hyperkalemia and different uremic complications. And some patients have required even dialysis because failure to recognize the AKI and continuation of tenofovir leads to progression of the acute tubular necrosis, and then the patient can have severe acute renal injury leading to sometimes requirement of dialysis. And again, not many of the institutions do have a facility for dialysis for PLHIVs because a separate machine is required. That is why it is very important to avoid or detect early this complication of AKI. So whenever there is AKI, we need to stop the tenofovir immediately. So we have to stop the ART TLD regimen. We have to completely stop. And then after stopping tenofovir, gradually the creatinine comes down. And if it is detected in time, and if we stop the tenofovir regimen immediately, the creatinine can come back to completely normal. So it is fully reversible if detected in time. Then coming to the, so this is one presentation. Now AKI because of tenofovir is a rare complication. However, we need to be aware and very alert about this complication, because if it happens, then we need to detect it timely, and prompt stopping of tenofovir will lead to complete reversal of the renal complication. Then coming to proximal tubular dysfunction. So that is known as Fanconi syndrome. Now, basically, we saw in the previous Reshu madam had showed you the slide on mitochondrial toxicities. So tenofovir also has this mitochondrial toxicity, which is focused mainly on the proximal renal tubular cells. So the mitochondrial toxicity here involves the renal cells of the proximal tubule. So there is a proximal tubular dysfunction, and this leads to non-absorption of different elements, and that's why we have a normoglycemic glycosuria. So there is a glycosuria, but the blood sugar will be, concomitant sugars will be normal. So unlike diabetes, where in Fanconi syndrome, the sugar will be normal. However, the urine will show sugar. So that is known as normoglycemic glycosuria. Then because of phosphate loss, so there is a glycosuria. Similarly, there is a phosphaturia. And because of this, the serum phosphate is low. So that is hypophosphatemia. Then there is a potassium loss in the urine. And so there is hypokalemia. And there are case reports where patients have presented with severe weakness, neurological weakness, like a hypokalemic periodic paralysis. So patients have presented with quadriparesis because of this weakness, and that is because of severe hypokalemia. Similarly, there is hypouricemia. Again, there is a hyperchloremic mild metabolic acidosis because of alkali loss in Fanconi syndrome, and there is a varying degree of proteinuria, which is tubular proteinuria. So what is the difference between the tubular proteinuria and glomerular disease proteinuria? Like we see HIV nephropathy. So that involves glomerular proteinuria. So the proteinuria is very severe. It is a nephrotic range proteinuria. Whereas this proteinuria because of tenofovir damage to the proximal tubule it is a tubular proteinuria. So it is a the proteinuria is not as severe as seen in glomerular diseases. It can be around 500 milligram to 1 gram or so. And then there can be amino aciduria. Now, many times this Fanconi syndrome can go unnoticed because the patient may not have much of symptoms, especially because this Fanconi syndrome can be just a partial. So patient can have just some glycosuria along with hypophosphatemia. Patient may not have a full-blown Fanconi syndrome, but this low-grade proximal tubular damage continues to occur, and then the patient will have a rise in gradually serum creatinine will start rising. And if this is still undetected, then the serum creatinine goes on rising and the patient goes into chronic kidney damage. So this is to be avoided, and that is why regular monitoring for creatinine is mandatory for all patients who are on tenofovir based regimen. That is why in our national guidelines, it is mentioned that any patient who is on tenofovir based regimen, there has to be a monitoring of creatinine every 6 monthly. So we will see that again, we'll review that guideline. So this was about proximal tubular dysfunction or Fanconi syndrome. So Fanconi syndrome will have this normoglycemic glycosuria, hypophosphatemia, hypokalemia, metabolic acidosis, proteinuria, and amino aciduria. Now, every ART center, we can easily do this urine sugar test. And we saw that for DTG toxicity, we are anyway doing blood sugar also monitoring. So whenever we are doing blood sugar, we can also include urine sugar, so that suppose the blood sugar is normal and we find that urine sugar is 1+, then immediately we can pick up on the proximal tubular dysfunction and we can promptly stop tenofovir so that the patient does not progress to having rise in the creatinine also. So if we stop it at that level, then the irreversible tubular damage can be prevented. So it is very important for every ART medical officer and counselors to have awareness of this Fanconi syndrome. And if we are able to detect it early by simple tests like urine glucose and blood sugar and serum phosphate level, we can also do serum potassium. These tests are easily available at most of the centers. And this way, if we find hypokalemia, we find hypophosphatemia, then that goes on to confirm somewhat that the patient is having proximal tubular dysfunction, and we can even give a SASEP referral to advise for change of regimen. Then there is a chronic kidney disease. So sometimes silently the renal damage, the tubular damage goes on, and the patient is completely asymptomatic. There may not be even the presence of Fanconi syndrome, but we find that the only abnormality the patient is having is a rise in creatinine. So any rise in creatinine when on a tenofovir based regimen has to be treated very seriously, and patient has to be observed. The trend of creatinine has to be observed. The patient has to be monitored, and if we will see that when we need to stop the tenofovir, that we'll be discussing in the subsequent slide. Next slide. So again, this is a very important slide to remember, that what are the risk factors for development of kidney injury due to tenofovir. Because if we are aware of these risk factors, then we will be monitoring these patients very meticulously. So if the patient has already a elevated serum creatinine at baseline, then such a patient is likely to be going into severe nephrotoxicity because of tenofovir, and tenofovir needs to be avoided in such cases, and we need to give these patients alternate regimens like abacavir based. Older age groups, again, they are more prone for tenofovir toxicity. Patients with diabetes mellitus and hypertension, they already have a baseline renal dysfunction. Their kidneys are compromised, and hence they are very, very prone to tenofovir nephrotoxicity. Now, many of the research studies or the studies in the Western, they showed lower incidence of tenofovir toxicity. However, in our observation, because the Indian population, diabetes and hypertension are very common, and even the PLHIVs, which we in our country, it's very common to have diabetes mellitus and hypertension in the PLHIV group. So they are very much susceptible and vulnerable to tenofovir toxicity, and that must be kept in mind. And any patient who is having diabetes and hypertension, we must very meticulously and regularly monitor the serum creatinine levels in these patients. Then advanced HIV infection, low body weight, hepatitis C, concomitant use of boosted PI. So if the patient is on, say, TL with atazanavir ritonavir regimen, then he is much more prone to nephrotoxicity. It is said that the nephrotoxicity incidence can go as high as 5 times when the patient is having a boosted PI concomitantly used with tenofovir. So again, when patient is on such regimen, tenofovir with atazanavir or lopinavir, then we need to, because ritonavir can increase the nephrotoxicity. So second line drugs, third line drugs where we are giving darunavir, ritonavir. In all these regimens, we need to be aware and monitor the serum creatinine. Then concurrent use of nephrotoxic drugs. So if the patient is having taking some other drugs which are also nephrotoxic, then again we need to be very vigilant for the nephrotoxicity because of tenofovir. Next slide, please. So given this potential for nephrotoxicity for tenofovir, we should avoid administration of tenofovir to those with the elevated baseline eGFR, which is less than elevated serum creatinine, that is eGFR less than 60, or elevated serum creatinine above the normal value. So we should try to give to other regimens like abacavir based regimen to such patients, and not give tenofovir in these cases, because their renal damage will be worsened. Then renal function and proteinuria should be monitored during the use of tenofovir. Ideally, during the first year, we should monitor every 3 monthly for renal function. So serum creatinine and urine protein, urine sugar, every 3 monthly for the first year. And then every 6 monthly, it is very, very important that every 6 monthly serum creatinine has to be monitored. Because if this is not done, and many times I have seen patients where for 1 year almost the creatinine was not done. And suddenly the patient, the patient comes directly with a creatinine of 3 or 4, where it could have been prevented by a timely stopping of tenofovir. So that is very important that you should, in your white card, you should see that when was the last serum creatinine done on, if any patient who is on tenofovir based regimen, please follow their white card charts and see to it that creatinine is done every 6 monthly. Then, as I said previously, monitor the urine for protein and sugar, and along with the blood sugar level, this urine for protein and sugar can detect the Fanconi syndrome very early. Then more frequent monitoring may be appropriate for patients with additional kidney disease risk factors. So patient who is having diabetes and hypertension, so patient is already having, maybe having a subtle underlying diabetic nephropathy, and so which this tenofovir can worsen this nephropathy. And so in diabetic patients, maybe we can have a more frequent monitoring. Next slide, please. So given this potential for nephrotoxicity of tenofovir, we in a patient, in a tenofovir treated patient who experiences a rise in serum creatinine, which comes to a GFR decline by more than 25% from baseline. So always we should, whenever we are starting tenofovir based regimen, especially in the elderly, diabetic, hypertensive at least, we should document the serum creatinine at baseline and then calculate the eGFR. And then suppose there is a rise in serum creatinine. Now we do not know whether this is tenofovir nephrotoxicity or this is it is because of say DTG we were talking just now. That DTG also can cause a minor elevation. Now, how do we know whether this is a minor elevation and it is not going to progress, or it is going to progress, or it is because it is tenofovir tubular toxicity, okay, or versus it is DTG based innocuous serum creatinine. So in these patients, if the creatinine rise is less than 25% from baseline, then we need not immediately substitute, but we should tell the patient, counsel the patient that his kidney function is getting deranged and he should come for frequent follow-up. So maybe we can do the serum creatinine frequently in such a patient, say weekly or twice weekly at least. We have to tell the patient to come back for the serum creatinine and document a serial creatinine. So if you find a rising trend and then the creatinine rises further and the GFR declines by more than 25% from baseline, that means there could be a tubular toxicity or this is a tenofovir nephrotoxicity. So then it is recommended to substitute to an alternative ART drug for tenofovir. Particularly this is in those patients with evidence of tubular dysfunction. So what will be the evidence of tubular dysfunction? There can be a mild proteinuria. So a urine dipstick may show 1+ protein. You can do other advanced tests like protein to creatinine ratio, but this may not be available at all centers. So a basic urine dipstick for protein. So protein detection of proteinuria, and you can do, as I said, urine sugar and test for potassium, serum potassium and serum phosphate. So it is very, very important to before deciding whether this creatinine is really clinically significant or not, we need to monitor that patient, do frequent creatinine, say at one weekly frequency, and then keep on calculating how much is the creatinine elevation, whether it is progressively increasing, and calculate the eGFR and compare it with the baseline. If it is really fallen by 25% from baseline, then we need to change the regimen. So what we need to substitute? So abacavir is safe for the kidneys. So abacavir is to be substituted for tenofovir. There is no need of dose adjustment for abacavir. So a full 600 milligram of abacavir can be given. Now lamivudine dose is to be adjusted as per creatinine clearance. So if the eGFR is more than 30 ml per minute, then full dose lamivudine can be given. That means abacavir 600 milligram and 300 milligram of lamivudine, it can be given. However, if the GFR is calculated eGFR is less than 30 ml per minute, then we may have to adjust the dose of lamivudine. So that we'll be discussing in subsequent slides how to adjust the dose of lamivudine. Next slide. Now coming to the spectrum of bone toxicity due to tenofovir. So tenofovir, as we saw, that here it has a tubular tubulopathy or tubular toxicity. So there is a loss of phosphate from the urine, and this hypophosphatemia over the long run, it causes loss of bone loss as measured by bone mineral density. So it causes a modest bone loss as measured by bone mineral density, that is done by DEXA scan after initiation of ART. So again, in different studies, in the last study in the United States, tenofovir was associated with a small but significant increase in fracture rates in the retrospective analysis study. And again, the cause of this is because of the bone loss. Again, tenofovir causing Fanconi syndrome, this leads to hypophosphatemia, and this causes osteomalacia. And so patient can have all over generalized bone pain. So any patient who is on tenofovir, who is complaining of bone pain, we must suspect bone toxicity, and we must suspect osteomalacia. So in such a patient who is complaining of bone pain on tenofovir based regimen, we can do again urine sugar and a serum phosphate. If the urine sugar is detected with normal blood sugar, if there is a hypokalemia and if there is a hypophosphatemia, then then it leads to confirmation of Fanconi syndrome. And again, we need to substitute tenofovir with abacavir to cause further, to avoid further bone damage. So that is very important. So all of us should be aware of this. So any patient on tenofovir based regimen who is complaining of persistent vomiting, please do not think that it is gastritis and just prescribe antiemetics. Think of nephrotoxicity, do a creatinine level. That is very important. And any patient on tenofovir based regimen who has persistent bone pain, then please think of bone toxicity and think of osteomalacia because of hypophosphatemia and do the relevant investigations. Next slide. So these are the references for the tenofovir nephrotoxicity and bone toxicities. Next slide. Now coming to the proactive approach for approach to manage ART drug toxicities. So we need to discuss the potential side effects of the drugs with the PLHIV and the caregiver before initiation, especially a patient who is high risk for say tenofovir nephrotoxicity. Patient is diabetic or hypertensive. Then we should tell the patient that he should come regularly for follow-up. If he develops any vomiting, unexplained nausea, vomiting, or pedal edema, then he should report immediately to the medical officer. So we should give them an idea about the possible side effects of the whatever regimen we are prescribing, and tell them to report to the ART center promptly if these side effects do occur. So this is during the early stages of treatment. So as a part of preparedness counseling, this is very important to discuss these side effects with the patient and make him aware. And it is important to differentiate any new clinical event after the initiation of ART from iris. Battery low is battery low. Always assess the toxicity and grade its severity. The management of toxicity depends on the grade of the severity. So we are going to discuss regarding the grade of severity in our subsequent slides, how to grade the severity. Offer support during minor and major adverse events. Now, this is again very important. Many times the patient is not adherent to the regimen because he has side effects. So mere counseling that he needs to be regular about the ART, he should take it regularly. Just, sometimes the medical officers who are busy, if they come to know that patient is not taking it regularly, they just send to the counselor, and the counselor just mechanically will counsel that patient should take it regularly. But if we do not address the minor and major adverse events, then the patient is otherwise is not going to be compliant. If he has the side effects, he's going to stop the drug. So it is very important. So ensure that the PLHIV is familiar with the signs and symptoms of toxicities that are serious and require immediate contact with the clinical team, especially in the case of efavirenz associated Stevens-Johnson syndrome, hepatitis, NRTIs-led lactic acidosis, or abacavir associated hypersensitivity reaction. So again, when we are now, abacavir is fairly being used as a alternate regimen. Any patient who is having not tolerating tenofovir, we are giving abacavir based regimen in our program. So any patient who is going on abacavir, we must explain that if on this regimen patient develops any new onset high grade fever or any rash, any itching, he should come back. So that is what is the counseling very important. Next slide, please. Now coming to the clinical signs. Clinical signs, symptoms, and management of adverse effects of ART drugs. So acute hepatitis. Now, as we said, the drugs which are currently relevant in terms of hepatitis is we are now using dolutegravir. We are not using the nevirapine and efavirenz. They are being phased out. So in the previous regimens, nevirapine and efavirenz were common culprits for hepatitis, and very rarely the NRTIs like zidovudine, stavudine. So hepatitis as a side effect of NRTIs is very rare, less than 1% charging. So what are the clinical signs and symptoms of acute hepatitis? Jaundice, liver enlargement, GI symptoms, fatigue, anorexia. And when it is associated with nevirapine, the hepatitis may also have a hypersensitivity component, that is the DRESS syndrome, drug rash, systemic symptoms, and eosinophilia. Now, in the current context, suppose the patient has hepatotoxicity, whether it is because of dolutegravir, that is the most important question to be decided. Now, whenever the patient is having some rise in the liver enzymes, it is very important to analyze the cause of this hepatitis. So many times it is very commonly, it is because of the co-prescribed AKT. So patient is on anti-TB drugs. So it is the AKT or the TB drug induced hepatitis. So we should check first that whether the patient is on any INH, rifampicin, PZM. That is basically the patient is taking TB drugs. That needs to be checked. And if the patient is on TB drugs, these drugs should be stopped immediately. Now, if the patient is not on TB drugs and the patient has hepatitis, then we need to examine the patient, take proper history in detail, and understand the circumstances of the hepatitis. Many times in India, for example, now it's a rainy season. All these tropical infections are very common. Like patients will have dengue, malaria, and leptospira. So patient can have hepatitis, even viral hepatitis can be there. So patients can have this tropical infections as a cause of hepatitis. So if we take a proper history and we get a history of fever with say rash, and if the CBC says thrombocytopenia, if the fever profile is sent and the fever profile comes positive, say for malaria antigen or dengue antigen or IgM dengue antibody, or so whatever the AFI, the acute febrile illness, is associated with the hepatitis, then we need not attribute that hepatitis to drug induced. So first we should rule out acute febrile illness as a cause. If that is not there and the patient has having just asymptomatic low grade elevation in the liver enzymes, many times patients can have fatty liver and associated NASH, non-alcoholic steatohepatitis. So that is commonly we are seeing NASH as a cause of liver enzyme elevation. Again, take a history of alcohol. Many times the patient is alcoholic and it may be a alcoholic hepatitis, as this had happened in COE-JJ, where a patient was referred for possible dolutegravir induced hepatitis, and we admitted the patient and we took a detailed history and sent all the liver enzymes and all the investigations. We ruled out hepatitis B, hepatitis C, and on detailed history, the patient then admitted of taking regular alcohol, and the pattern of the liver enzymes was such that SGOT was more than SGPT, suggesting a alcoholic hepatitis. And then the patient was counseled, and his alcoholic hepatitis slowly resolved, and then the patient was continued on DTG based. And it is very important to again monitor the LFTs, whether they are rising. If suppose it is drug induced, then continuing the drug leads to further progressive rise in the LFTs. So always it is preferable to admit such a patient in a internal medicine ward. The patient can be referred to either a medical college or district hospital, or maybe if there is a facility of gastroenterology opinion, that can be taken. And after proper evaluation only, we should label it as dolutegravir induced hepatitis. Next slide. Then coming to acute pancreatitis. Now the commonest culprit drug responsible for acute pancreatitis in the previous program, where stavudine regimen was frequently used, was stavudine. Again, basically here I want to mention that pancreatitis is again a manifestation of the mitochondrial toxicity. It is a NRTI class effect. So all NRTIs can lead to pancreatitis. Now, which are the NRTIs which are most likely to cause most pancreatotoxic? Stavudine and diadenosine. They are the most pancreatotoxic NRTIs, followed by zidovudine. Zidovudine also having some pancreatotoxicity. After that, tenofovir, abacavir, and lamivudine, they have the least pancreatotoxicity. But however, they also still can some pancreatic toxicity. So if the patient is on tenofovir lamivudine based regimen, TLD, and he is having pancreatitis, then if after stopping the drugs, we again restart the same TLD regimen and observe that the pancreatitis recurs, then we need to again change this regimen. So we cannot use a NRTI regimen if the patient is having severe recurrent pancreatitis, and we need to give a regimen which is non-NRTI based, like say DTG with PI combination. Otherwise, the patient goes on to have progressive pancreatic toxicity. So here also, if the ART medical officer can take a detailed history, and maybe he can do a SASEP referral and take advice regarding whether the regimen needs to be changed or not. Again, there can be concomitant other causes for pancreatotoxicity, like gallbladder stones, or the patient can be alcoholic, and drugs like Septran. So all these things can add to the pancreatotoxicity. That's why it is very important to study the patient's case by case individually. We need to see all the causes and then decide regarding the ART regimen. Next slide. Coming to again lactic acidosis, this is also another mitochondrial toxicity, and again this is a class effect. All NRTIs can lead to lactic acidosis, but which are the most culprit NRTIs? Again, stavudine. Stavudine is no longer being used in our current program, but we are definitely using zidovudine, and zidovudine also can cause severe lactic acidosis. Now the tenofovir and abacavir, they have lesser incidence of lactic acidosis. However, in a patient whom we are suspecting lactic acidosis, and suppose the patient had lactic acidosis because of zidovudine, and then we have substituted tenofovir for that patient, we still need to monitor and see whether the lactic acidosis recurs. If the lactic acidosis recurs even on tenofovir, then again here we may have to give a regimen which with no NRTI. So again, like DTG with PI combination. Now, what are the presentation? How do we suspect lactic acidosis? So we should know the scenario or the setting of lactic acidosis. Generally, lactic acidosis, it is seen in a patient who is on a very long-standing NRTI regimen. So patient may be taking this NRTI regimen. Patient may be initially on stavudine for years together, 10 years, 8-10 years of NRTI. And symptoms can be quite variable and non-specific. That's why awareness of this syndrome is very important. The symptoms are so non-specific that it can be completely missed. So a clinical prodromal syndrome, so it may include just generalized fatigue and weakness, GI symptoms like nausea, vomiting, diarrhea, abdominal pain. So typically the patient is a patient who is complaining of, persistent abdominal pain, patient is having persistent vomiting, severe weight loss. but a sonography will just show some hepatomegaly, nothing else. Okay, so there is no OI like TB to account for the weight loss. And one peculiar observation of the patient can be tachypneic. So this tachypnea is because of the acidosis. So if you observe such a patient, then we should immediately do the arterial blood gas or refer the patient to an institution where all these facilities are available. So ABG will show severe acidosis, which is a high anion gap acidosis. And if we do the serum lactate level, they will be high. So in that case, how do we manage? That we promptly discontinue all ART. The symptoms may continue for some time or even worsen after discontinuation of the ART. But we have to give this symptomatic treatment, IV fluids and support. Appropriate therapy has to be given. And while resuming ART, we have to be very cautious. If we are giving, say, whatever NRTI was there, we have replaced it with abacavir or tenofovir. We still need to monitor for recurrence of lactic acidosis. If the patient does not have any recurrence, then we can continue that. Otherwise, again, we need to change the regimen. Next slide. Now coming to the hypersensitive reaction. Now in the today's context, abacavir, we are using it very commonly. So we should be aware of the abacavir hypersensitive reaction. So it is a constellation of acute onset of symptom, including fever, fatigue, myalgia. So sometimes we have seen that patient may not have rash immediately, but immediately after starting abacavir, patient gets high-grade fever. There can be fatigue, lot of body pain, myalgia. Patient can have nausea, vomiting, and diarrhea. So GI symptoms can be there. Fever can be there. Abdominal pain, pharyngitis, cough, or dyspnea. So all this can be with or without rash. So even if there is no rash, still, if patient has all these symptoms, we must suspect promptly about abacavir hypersensitivity and stop the culprit, stop abacavir. Now these symptoms can overlap to some of the symptoms of common infectious illnesses, but it can sometimes mislead us. We think that this is a viral fever, but the temporal onset, like the timing. So immediately after starting abacavir, if all these symptoms are occurring, then that points towards the abacavir hypersensitivity. So we have to discontinue all ART. In that case, completely stop the whole regimen. So patient may be on abacavir, lamivudine, DTG. So stop this whole regimen, and then just we have to administer supportive therapy. Maybe the patient needs to be hospitalized, and we should never re-challenge again with abacavir, because there can be a severe anaphylactic reaction and even death. So again, the gastrointestinal symptoms and respiratory symptoms, if they are combined, that is more typical of a hypersensitivity reaction. Nevirapine we are not so much using, but we should be aware that similarly fever, myalgia, arthralgia, hepatitis, that can also occur with nevirapine. Next slide. Now we should remember that now when we want to discontinue that abacavir based regimen, we need to do a referral to either SASEP or proper referral for again substitution with another drug. Now coming to rash or drug eruptions like Stevens-Johnson's. So this was again more common with the nevirapine and efavirenz. Now they are being phased out rarely, but this can also be seen with dolutegravir and lamivudine. So the whatever with efavirenz and nevirapine, the rash generally occurs in the first 2 or 4 weeks. It can be maculopapular, erythematous, and whenever there is mucosal involvement. So mucosal involvement indicates that it is a severe rash, and any patient who is on, say, nevirapine or efavirenz, and when such a rash comes, prompt discontinual will be very important. And if it's a grade 3 or grade 4 rash, then we cannot give any NNRTI. Like if we had given nevirapine, we still cannot give efavirenz if it is a severe grade 4 rash, like if there is a Stevens-Johnson syndrome or toxic epidermal necrolysis. Next slide. Coming to peripheral neuropathy, with the stavudine regimen, it was common. There was pain, tingling, numbness, distal sensory loss, and if it was detected early, then it was reversible. Next slide. Coming to diarrhea. Now, in our current context, we were using lopinavir, ritonavir very much, but now again, lopinavir, ritonavir use is now only restricted to PL-HIV with HIV-2, but still HIV-2 patients, though they are on TLD regimen, some of them may be on lopinavir-ritonavir regimen. And so we should be aware about the adverse effect, that is loose motions or watery diarrhea. Now the loose motions because of lopinavir-ritonavir is usually self-limited. There is no need to discontinue ART. So symptomatic treatment may be given. We can give oral rehydration solution if it's a watery diarrhea, and slowly it is expected that the diarrhea resolves. However, if the diarrhea is not controlled and it persists and the patient continues to suffer with diarrhea, then we can switch to atazanavir-ritonavir, because the dose of ritonavir is less in atazanavir-ritonavir combination, and mostly the diarrhea is because of ritonavir. Coming to dyslipidemia, insulin resistance and hyperglycemia. Now we are very much aiming for monitoring for sugar and lipid profile, to monitor the toxicity profile of all our ART. So the offending possible drugs for dyslipidemia are mostly the protease inhibitor drugs and efavirenz. So any patient who is on protease inhibitor regimen, it may be atazanavir-ritonavir, or it may be, however, atazanavir-ritonavir, as we saw in the previous talk, that it has a much lesser effect on lipid profile. And then we have other third line PIs like darunavir-ritonavir. So sometimes it may not be possible to replace the suspected PI by drugs with less risk of metabolic toxicity, as the management is suggested. But definitely we can be aware, and we can substitute with a lesser PI with lesser effect on lipid profile, or we can give some treatment with statins, drugs with which will reduce the cholesterol levels. So we can use statins, we can prescribe statins in such a patient. So monitoring the lipid profile is very important. Next slide. Coming to GI intolerance. So GI intolerance can be seen with any ARV, and symptoms are like vomiting and nausea, gastritis, indigestion. So it is usually self-limited. However, it is very, very important to note that before labeling the patient's symptom as gastritis because of ART, we need to rule out the more serious causes. Very important. So we need to document a creatinine which is normal, because nephrotoxicity, as we saw, tenofovir nephrotoxicity commonly presents with vomiting. Similarly, DTG hepatitis, any hepatotoxicity, or AKT-induced, TB drug-induced hepatitis also presents as vomiting. So whenever a patient says vomiting, ask also for pain in abdomen. If there is severe pain in abdomen, it can be pancreatitis. So pancreatitis, hepatitis, and nephrotoxicity. These are the three things. After ruling out these three possibilities, then we may say it is gastritis. So how do we rule out? The creatinine should be documented. The liver function tests should be documented, at least a bilirubin with liver enzymes, SGOT and SGPT. And if needed, if there is pain, tenderness and pain in abdomen, then a sonography and a serum amylase and lipase can diagnose pancreatitis. So we need to rule out these serious toxicities before then labeling the patient as having to be gastritis. So if the patient has only gastritis and no other cause, then we can just prescribe. It is generally self-limited, and we may not have to discontinue the ARVs. However, sometimes the patient who is having refractory vomiting, which is not responsive to symptomatic treatment, maybe sometimes the patient requires a OGD-scopy. So again, referral to a higher center where this is possible, because I've seen some patients. I had one patient who had refractory vomiting, and on OGD-scopy we diagnosed esophageal candida, and sometimes it is a severe acid peptic disease which is discovered on OGD-scopy. So again, it is very important to take proper history and do a proper evaluation. Coming to hematological toxicity, in the current context, now we are using zidovudine very much in the program. It is a zidovudine is sort of, it is one more backbone now, because patients who are going to fail on TLD are now going to go on zidovudine as a second line. So again, patients many of the patients are on zidovudine based regimen. So we should be aware of all the toxicities. So mainly it is anemia, the bone marrow toxicity of zidovudine. We should remember anemia and leukopenia. So how will the patient present with fatigue, breathlessness, and palpitation? So if the HB is very low, that is HB is less than 6.5 and or the absolute neutrophil count is less than 500, then we need to substitute with an NRTI that has less effect on the bone marrow, like tenofovir or abacavir. And we may, if the HB is very low, say 4 gram, 5 gram, then we may also consider blood transfusion. Next slide. Then coming to lipoatrophy, this is again seen with all NRTIs, particularly stavudine. Lipodystrophy syndrome, it is dyslipidemia consisting of elevated cholesterol and low HDL levels, elevated triglycerides. There can be insulin resistance with hyperglycemia, and there can be central fat accumulation with visceral breast neck fat accumulation, and there can be buffalo hump. There is also association with diminished of subcutaneous fat mass, that is lipoatrophy. So lipoatrophy includes the loss of subcutaneous fat in the face, extremities, and buttocks. Now, in the management, if it is feasible, we can replace suspected ARV drugs. Like previously, if it was stavudine, it was possible. Now, but however, we have observed again lipodystrophy or atrophy with even tenofovir-based regimens and all NRTIs. It is a class effect again. So many times we have to really counsel the patient. We can consider aesthetic treatment and physical exercise. And if the lipid profile is deranged, we need to give again treatment for that, including statins. Next slide. Coming to neuropsychiatric changes, efavirenz, we are all aware, but as we saw, even dolutegravir does have some effect on sleep. We saw that insomnia as well as somnolence can be side effects of DTG. So basically, we need to talk to the patient how that side effect is impacting his life. For example, I remember patients who are drivers, taxi drivers, and if they have this effect, of all these CNS side effects, then their job is lost. They cannot do their job. So if that is the case, then we need to change the drug. So definitely we need to consider what is the patient's occupation and how severely this side effect, neuropsychiatric change, is affecting the patient's life. That is important before we take a decision. So then coming to renal toxicity, renal tubular dysfunction, we have already discussed in the previous slides. Next slide. Now, clinical signs, symptoms, and management of adverse effects. Yes, so suspecting or holding NNRTI may not always be appropriate because sometimes for example, for the drug rash, including Steven Johnson's or 10, the NNRTI or the NRTI may not be the culprit drug. It can be even because of the co-trimoxazole, which is co-prescribed with the ART. So that can be an offending agent. Also, there are sporadic reports on skin rashes induced by any of the ART like zidovudine, lopinavir, atazanavir, ritonavir, darunavir, raltegravir, DTG, and lamivudine. So any of the drugs used in the ART regimen can cause drug rash. So it is very essential to identify the offending drug before the appropriate action is initiated. Next slide. Now here there is a outline whether how do we approach a patient who is on DTG based regimen, say TLD, and he gets rash. So basically, I'll just tell the summary that if the patient has rash on TLD, then we can give TLE. Now, if the patient tolerates TLE, but he had rash on TLD, that means that confirms DTG hypersensitivity. And then in that patient, we can think of substituting the DTG with other drug. Again, in case of severe rash, we need to stop all ARV and cotrimoxazole also. Once the patient improves, then we need to start the ART without cotrimoxazole. So patient say suppose was on TLD with cotrimoxazole, we need to stop cotrimoxazole. First stop all the drugs. Then once the rash completely subsides, then give only TLE without cotrimoxazole. So patient tolerates the TLE, then that means DTG hypersensitivity, and we need to substitute the DTG with say now efavirenz is also getting phased out. So maybe the patient will have to be on TL with ATVR regimen. Now, if on TLE also the patient gets a rash, that means the culprit drugs is not DTG, then we have to give TL. With TL, the patient has rash, that means either tenofovir or lamivudine. Now, only tenofovir rash is rare, so it is most likely to be lamivudine rash. So you can give only tenofovir as monotherapy. If the patient tolerates it, then it is lamivudine rash. So if the patient's lamivudine rash is confirmed, then we give a new drug regimen, that is tenofovir, zidovudine, and dolutegravir. So a regimen without lamivudine. If the patient has rash with tenofovir, it is tenofovir induced rash, then we can give abacavir, lamivudine, and DTG for such a patient. Next slide. Now coming to grading of drug toxicities. So basically we need to properly grade the toxicities into 4 grades. Grade 1 will be mild, grade 2 moderate, grade 3 severe, and grade 4 is potentially life-threatening. Next slide. So how do we grade? So mild rash is it is minimal symptoms with no interference with usual social or functional activities. Moderate grade rash, moderate grade toxicity means symptoms causing greater than minimal interference with usual social and functional activities. Severe toxicity means symptoms that is grade 3. It is causing inability to perform the usual social and functional activities. So the patient just cannot go along with his day-to-day life. He's having so much of toxicity. That is severe, grade 3. And grade 4 is potentially life-threatening. Here the patient is it is causing inability to perform basic self-care, or the patient requires a medical or operative intervention, and patient needs hospitalization, so to prevent a permanent impairment or disability or death. And grade 5 toxicity is actually death. Next slide. So again, for this is a guideline what we should do for once we grade the toxicity. So if the grading of toxicity is grade 1 or 2, then generally the changes of ART should be avoided, but it is very important, it is written observe. That is very important, because we have seen, suppose the patient had rash, initially it was grade 1 rash, but the patient needs to be called daily to the ART or maybe hospitalized also to observe him, because this grade 1 rash can then progress to grade 3 or grade 4 rash also. So it is very important to keep on observing that patient. So if the toxicity remains grade 1 or grade 2, then we can continue to observe and just continue to cautiously continue the drug under observation. But the patient keeps on now progressing to higher toxicity grades, then definitely a change of regimen needs to be done. Next slide. For grade 4 toxicities, it is important to hospitalize the patient and give the necessary treatment. So here I would recommend that it is impossible to memorize all these grades of toxicities. Here we have given shown the tabular form where all the grades of toxicities are mentioned for hemoglobin, absolute neutrophil count, platelets, hyperbilirubinemia, glucose, hypoglycemia, and hyperglycemia. So these are all the toxicities which you are seeing. Hemoglobin and neutrophil count we are seeing for zidovudine, and you can see what are the different grades: grade 1, grade 2, grade 3, and grade 4. So as recommended, grade 3 and grade 4 is where we should take action of changing zidovudine. But up to grade 1 or 2, we can just cautiously observe the patient. Again, in anemic patients, it is recommended that patient, any other cause for anemia like iron deficiency, B12 deficiency can be worked out. Such investigations can be done. If it is a mild anemia, we can see that if there is any other factor causing anemia, we can treat that. Again, for platelets, it is the myelotoxicity of zidovudine. So it's mentioned. So grade 4 toxicity, for example, for platelets is less than 20,000. Similarly, for hyperbilirubinemia, it is more than 1 to 1.5 upper limit of normal, and then subsequently more than 5 times upper limit of normal. So bilirubin more than 5 will be grade 4. Similarly, for fasting sugar, sugars of more than 500 is a grade 4 toxicity. So I would recommend that all this table of grading of higher toxicities, that can be a printout can be taken, and it should be kept on the table under the glass for ready reference. So any patient who is having such toxicity, we can immediately see the table and then grade the toxicity accordingly. Next slide. So this is an annexure. Again, here also in this table, you can see the different grading for the different toxicities. So triglycerides, then for creatinine. Now creatinine, what I want to point out here, the approach is slightly different. What we discussed that for grade 1 and grade 2, we need not change. But for tenofovir, the approach is different, that we need to pick it up as early as possible and monitor. And if we find that the creatinine is rising and a fall of more than 25% of baseline from the baseline GFR, we should promptly stop the drug. So here we cannot, say that it is just mild grade 1 and grade 2 and we need to continue. For tenofovir, it is different. So nephrotoxicity, because tenofovir, we should stop the drug promptly. Then similarly, other drugs, other toxicities are here mentioned for OTPT, for hepatitis, then alkaline phosphatase again for hepatitis, bilirubin, amylase for pancreatoxicity, and pancreatic amylase, lactate for lactic acidosis. All the different grades of toxicities are mentioned, and you can just see them. And you can again keep these tables handy for reference whenever required. Next slide. Again, nausea, vomiting, I had elaborately discussed before labeling them as gastritis. And before grading all this, it is more important to see the cause of nausea, vomiting, whether it is hepatitis, whether it is nephrotoxicity or pancreatitis. And that evaluation is also required apart from grading the toxicity. Diarrhea also, again, it is mentioned. Next slide. Respiratory and urine related. Again, the proteinuria, 1+ on dipstick, 2+, 4+, and frank nephrotic syndrome. So that is mentioned over here. And dyspnea. Dyspnea is generally seen. It is any regimen causing acidosis. So it can be lactic acidosis, or if the patient has nephrotoxicity, it can be a severe metabolic acidosis because of renal failure. So that can cause dyspnea. Any OI can cause dyspnea, like PCP, pneumonia can cause dyspnea. So you can grade the dyspnea. Next slide. So miscellaneous: fever, headache, allergic, then rash and fatigue. Again, there is a grading available that we can go through. Next slide. So lastly, I'll just take 5 minutes more, though we are running over time. I'm sorry, because it's a very elaborate, this topic is very big, and we needed to have some detailed discussion previously. So lastly, in 5 minutes, we'll summarize. So drug substitution, as you all know, next slide. So when substitution, as you all know, it refers to replacement of ARV drug in a PLHIV due to toxicity or adverse effect of drug, or any drug-drug interaction or program policy. So this does not indicate change of regimen due to treatment failure. So basically, it is just a change of 1 or 2 drugs in the regimen and not the entire regimen. Now, delaying substitution when there are severe adverse drug reaction may cause harm and may affect the adherence. So that is very important. So whenever the patient is not adherent, please look for drug toxicity and promptly address the drug toxicity. Coming to switch, it indicates entire treatment failure. So it refers to the loss of antiviral efficacy to current regimen and triggers the switch of the entire regimen from first line to second line or second line to third line ART. So that is very important. Next slide. So the general guidance in drug interruption, but general principle is that single drug substitution for toxicity should be made with the same ARV class. Now, whenever we are doing a single drug substitution, we should be sure that there is no ART failure. So always it is preferable to do a viral load, and confirm that there is no ART failure, and then do a single drug substitution. So many times we are not, the CD4 may not be a guide. So if we need to do a single drug substitution for toxicity, and if we do not have a recent viral load available, please try to have a viral load before you do a single drug. Otherwise, if it is a failing regimen and then we do a single drug substitution, then it does a lot of harm to the patient, because now that new drug will also start becoming resistant. That is very important to keep in mind. Then if a severe or life-threatening toxicity occurs, at that time, all ART should be stopped until the toxicity has resolved. For example, severe anemia because of zidovudine, stop the entire ART. Or tenofovir nephro-AKI, patient's creatinine is 6, 7, stop the whole regimen. Okay, and then later on, once the patient stabilizes and the toxicity is all managed, after that a revised regimen can be commenced. So there is no hurry. First the patient should be stabilized, and the life-threatening toxicity should be dealt with. If the patient has AKI, the dialysis and all that management needs to be done first. Then the ART can be substituted. Whenever an ARV toxicity is suspected, again rule out other OIs or other conditions that may be responsible, and always grade the toxicity according to the severity. Next slide. Drug toxicity and substitution. Again, for zidodine, suppose zidodine has some side effect like lactic acidosis or anemia, we can substitute with tenofovir. For abacavir, if there is hypersensitivity reaction, we can give either tenofovir, or if it is contraindicated, then zidodine. For tenofovir nephrotoxicity like Fanconi or bone mineral toxicity, then abacavir can be given. Next slide. For efavirenz and nevirapine, we are anyway phasing out. So for DTG toxicity, now any complication because of DTG, what we can give is, we can give efavirenz based regimen if it is available. That there should be TLE stock available if you want to substitute TLE. Otherwise, we can give PI as a replacement. So for example, if DTG toxicity, if the patient is on TLD and efavirenz is not available, then we can give TL-ATVR based regimen. Now, if there is a atazanavir ritonavir intolerance, especially if the bilirubin is very high, say 10, 11. So though there is no hepatotoxicity, atazanavir ritonavir causes a Gilbert-Reich syndrome. So it's just a rise in the indirect bilirubin. The liver enzymes may be completely normal, but still the patient, if he is not tolerating, he is having some GI complaints, then we can substitute DTG. Similarly, for lopinavir ritonavir intolerance, we can give DTG. And multiple NRTIs which are having toxicities intolerance, like we said, class effect, there is pancreatitis severe with all NRTIs. Then we can give again DTG with appropriate PI. Next slide. Hepatotoxicity or hypersensitivity reaction. So this is for dolutegravir, the management of adverse effects including substitution. So already that was discussed in the previous talk. So for co-infection with hepatitis B and C and there is a hepatotoxicity, then we can substitute it with another therapeutic class, like for example, efavirenz if available or boosted PI. For insomnia, the risk factor is older than 60 years, considering substituting with raltegravir if available or boosted PI. Weight gain, we need to monitor the body weight and promote anti-obesity measures like diet, counseling and physical exercises. And if there is a significant increase despite all measures, then we need to consider substituting with either boosted PI or efavirenz if available. Next slide. Lastly, as we said, we are going to discuss about drug substitution guidance in impaired renal function. So as we elaborately discussed, whenever there is impaired renal function with fall in GFR and elevation in creatinine, and it is progressive accompanied with proteinuria, then we need to change the regimen to abacavir. We need to stop tenofovir. So the preferred drug regimen in such situation is abacavir, lamivudine and DTG with dose adjustment of lamivudine according to creat clearance. So full dose of abacavir 600 mg is given. If the creatinine clearance is more than 30 ml per minute, then lamivudine also can be given with 300 milligram full dose. But for patients with creatinine clearance less than 30 ml per minute, then we have to adjust the lamivudine dose. So lamivudine dose can be from creat clearance of 15 to 30. We can give lamivudine dose of 150 milligram. So at many centers, this tablet of abacavir 300 with lamivudine 150 is available. So here we can give this tablet of abacavir 300 with lamivudine 150 plus abacavir plain 300 along with DTG. And if the creatinine clearance is less than 15 ml per minute, then lamivudine 100 mg single tablet may have to be given. If it is not available, then we may have to give full dose of abacavir 600 plus lamivudine, but we need to do close monitoring because there can be side effect of lamivudine. Now, whenever a full dose of lamivudine goes here with no adjustment, we have seen at JJCOE, some of the patients had severe pancreatitis. So definitely we must be aware of this complication and we need to monitor. And if the creatinine clearance worsens, then the ART must be stopped and also then the case must be referred immediately for SUSEP opinion and take guidance on the dosages. Next slide. So thank you for your patient hearing. We had to go a bit overboard. I'm sorry for that. Thank you.
Thank you, ma'am. Thank you to all the participants for patient listening. Kiran sir, can you please give mic access to all the participants now?
Ma'am.
Thank you. Ma'am, I'm just checking the questions from the chat box. Meanwhile, participants are requested to please unmute their mic and ask questions.
Ma'am.
Yes, sir. Please go ahead.
मैम मेरा ये क्वेश्चन है कि
जैसे इसमें लिखा है कि if creatine clearance worsen then ART must be stopped and case must be referred immediately for सेसअप। तो ये creatine clearance अगर कितने से नीचे आना शुरू हो जाए तो हमको सेसअप के लिए करना है, हम क्लोज मॉनिटरिंग कर रहे हैं तो।
Like I said ना, the creatine clearance baseline से अगर 25% से fall हो गया है, जो भी baseline creatine clearance था
जी
से 100 clearance था baseline आपका
जी,
और अभी creatine clearance 75 तक आ गया या 60 हो गया, तो यानी 25% से कम हो गया, ठीक है। तो अगर 25% से ज्यादा से फॉल हो गया है तो देन हमको इमीडिएटली वो बंद करना है, क्योंकि हम कंटिन्यू करेंगे तो और फिर प्रोग्रेसिव रीनल डैमेज होना होगा। तो इन दैट केस आप फिर ससेप को रेफर कर सकते हैं।
ओके मैम, थैंक यू मैम।
Ma'am, I'm from ARTC Bhubaneswar.
Yes.
My question is, have you seen ever lamivudine-induced peripheral neuropathy?
Yes, we have seen few cases. Yes.
In those cases, what is to be done actually? How to manage that?
Yes, then we cannot give lamivudine. So basically, we need to take a neurology opinion, specialist opinion, and nerve conduction velocity, and also rule out any other cause before we attribute the neuropathy to lamivudine. For example, patient may, if he's on AKT, then INH can be the responsible drug, or patient can be alcoholic, then alcoholic neuropathy. So if any other cause of neuropathy or HIV neuropathy also may be there. So if still the neurology opinion and the physician, they feel that it is because of the drug, then we can change the drug and see. In that case, a regimen without lamivudine. So then you can refer to SUSEP, where probably then DTG and PI regimen. So where the lamivudine is not required, no? So that we can give after SUSEP. Any other question?
Ma'am, there's one from the chat box. Can we undertake a desensitization protocol as we do in INH and CTZ sensitivity for new PLHIV on TLD, developing grade 2 or 3 drug reactions?
Actually, this drug sensitization protocol, maybe, it is, I would say it is risky to be done at an individual physician's, custody. Maybe such a patient should be referred to a hospital or institution where the patient is hospitalized, and then these things can be done. Because if the patient develops a severe reaction, even while during this desensitization, then we should be able to manage it. So under observation and preferably under a institutional hospitalization, we can maybe do it.
Ma'am, hello, I'm from Barampur, ART Center, Barampur. Madam, in some of the cases, we find the platelet level is very much decreasing.
Okay.
Even it comes to less than 5,000 or 10,000 like that.
Okay.
So what may be the cause, or what should we do in those cases?
Okay. So, we have to see whether isolated thrombocytopenia is there or it is a part of a pancytopenia. अगर pancytopenia है, so along hemoglobin भी कम है and everything, WBC is also falling and platelet, then we should check whether the patient is on zidovudine, because it is a bone marrow toxicity, complete myelotoxicity. But if the patient is not on zidovudine based regimen and only the thrombocytopenia is there, then this is mostly because of HIV per se causes thrombocytopenia. So it's like a ITP sort of thing. It is an immune thrombocytopenia. So in such a case, if it is so severe, then you need to do a say a SASEP referral and also maybe a hematology referral where they give steroid. So you have to see what is the CD4 count, whether there is any OI, and whether steroids can be given safely, and giving prompt ART to such patients, because this ITP associated with HIV responds to prompt ART. So if you start the patient on ART and any ART, but try to avoid zidovudine in these cases. So this ART, after say 3 to 6 months, the platelet counts will start rising and responds to ART regimen. Till that time, we can give steroid also.
Thank you, ma'am. Any more questions? Yes, sir. So please go ahead. We can hear you.
Hello.
Yes.
Yes, sir.
Yes,
Is
sir.
it audible? Okay, this
Yes,
is Dr.
yes.
Swami from Mysore.
Yes.
Madam, I have two questions. One is regarding the creatine clearance of more than 30 ml. You said you have to give full dose of lamivudine.
Yes, that is a NACO guideline.
Yeah, what is the scientific evidence behind this giving like more than, because usually we follow above 50. Is there any scientific evidence for this? Number one. Number two, we have another question is about regarding the switching of therapy. Say, for example, patient failed on multiple NRTIs. So we're going to start like 2 drug regimen like that, like for example, Adazaretinib with DTG or Darnavretinib with DTG. But they say continue with the existing NRTI group. So what is the basis on this, madam?
Yes. So
regarding your failing, we still want to continue. Why?
Yes. So regarding your first question,
yes,
that scientific evidence.
Yes,
basically, ideally, it will be good if we adjust the lamivudine dose, especially from 30 to 50. In that group range, maybe the lamivudine dose comes to 150, but we are giving it as 300 because this is for the programmatic convenience. It is such a large scale. This lamivudine, plain lamivudine of different like 100 mg and 150 strengths, it may not be available so widely.
That is why may indirectly harm the patient. Kidney can be damaged.
No, but yes, it is given in some recommendations. Like I have seen this recommendation in the site of UpToDate, which is a very standard site by even United States. So there, it is an alternative recommendation. It is given in their site regarding lamivudine. If you see the lamivudine chapter in that, they have given that if it is not feasible to give this dose as per the creatinine clearance, then we can give the higher doses, but with frequent monitoring. So if you can monitor the patient and watch for side effects, then it is generally not so toxic because lamivudine is not having so much of toxicity. So we need to monitor. Okay. That is the first answer to your first question. And regarding the second, so we are continuing the NRTI backbone. Now, there are 2 reasons I would say for this. First reason is the lamivudine, which is there in the NRTI backbone, that impairs the ability of the virus to multiply. So lamivudine has that advantage. Okay. And second thing, what I have observed many times. Yes. Can you hear? There's some noise. Yeah. So continuing the lamivudine part in the NRTI backbone has this advantage, and whatever susceptibility, if we are many times what happens is the failure which we are documenting, it may not, sometimes it is not because of proper adherence. And then we take a decision based, always it is not possible to cross check the adherence, and sometimes the decision is taken to change. So if we are retaining the NRTI, and if we are also not doing genetic susceptibility testing because it is very expensive and this is a program, so we are not able to check for individual drug sensitivities. So if we are including more drugs in the final regimen, because in the 3rd line regimens or the 2nd line regimens, now the patient is going to have a lesser option. So, having a broad spectrum, including more drugs will, prevent further resistance. So that is one more approach in that.
But why not we consider only lamivudine? Why should we give like tenofovir or abacor or
no, because lamivudine giving only lamivudine is difficult. So now many times when we are giving, retaining TL, so we can give it as TLD. In the 3rd line regimen, we want to have the TL backbone there. So then TLD is a convenient regimen and it is only 1 pill. Okay, so it is a ease of administration and less pill burden. So that, because again, otherwise we have to give separately lamivudine also. Okay.
But madam, here in our SESAP meetings and all, but nobody is following these guidelines. Just they give 2 drug regimen only, Darnavretinib with DTG or Adazaretinib with DTG. Nobody is giving the existing NRTI group.
Okay, then what we'll have to do is you have to talk to the SESAP authorities, whoever are evaluating your patients, because in JJCOE we are now following these guidelines and we are retaining the NRTI backbone. So you need to talk to your SESAP authorities regarding the why it is not being followed.
Thank you, madam.
Yeah. Ma'am, we have got a patient who is getting dolutegravir and lopinavir based regimen.
Yeah.
He started developing, he developed tuberculosis.
Okay.
And rifabutin is not available.
Yeah.
So how to manage this case?
Yeah. So this is now we are facing this problem because of non-availability of rifabutin all over India. So in the TRG meeting, which was conducted, I think it was last year, it was decided now to tide over the crisis. So till rifabutin is available, it was decided that the super boosting and all, if you have to super boost, then the PI dose goes very high, and the patient they are not tolerating. Many of our patients, when we try to do that, so then it was decided in the TRG meeting that we will give levofloxacin instead of rifampicin in such cases. However, we need to give levofloxacin based regimen for a longer time, because there is chance of developing resistance without a rifampicin based regimen. So for the intensive phase regimen can be given for 3 months in a levofloxacin based regimen, and then maybe instead of 6 months continuation phase, we can give it for 9 months with a levofloxacin base. So that is one way we can deal that.
Madam, we can maintain other components as usual.
Yes. But so you will have to give individual
only
drugs.
rifampicin is to be replaced with
Yes, levofloxacin.
How
Yes.
much? What is the strength? Levofloxacin.
Levofloxacin, you have to adjust as per the weight, but generally it comes to 500 mg dose, 500 OD. If the weight is say of around 40-45 kg, 500 OD. If it is the weight is higher, then maybe 750 mg OD.
Okay. Thank you. Thank you.
Hello, madam. Hello.
Yes.
The Tirupati, Andhra Pradesh ART Center, madam.
Yes, sir.
This is just to share my observation.
Yes.
Previously, when we started TLE to TLD transition, and when we followed the guidelines about this informed consent for women in the reproductive age group,
yes,
we found that in the first week, most of the women who are slightly educated, they said, no, let us continue from the old regimen. From then on, we have been focusing less on that informed part of the consent.
Yes.
This is my practical experience. Otherwise, you would not have been able to transition a lot of young women from TLE to TLD. Because
yes,
they explicitly take the most frequent response to this informed consent counseling is, sir, you are the doctor, you know best, you please tell us properly.
Yes.
So this is a very difficult thing to manage on the ground.
No, and now we can be positive about the DTG, because we have seen that now the evidence is that DTG is not causing so much of neural tube defects anymore. So we can focus on counseling on the positive effects of DTG. So definitely that can be changed while taking an informed consent. Thank you for the feedback.
Ma'am, there's a question in the chat box.
Yes.
Kindly clarify about NACO strategy about the availability of separate pill of abacavir and lamivudine as to modify the dose of lamivudine as per EGFR.
Yes, so that's what, if the creatinine clearance is more than 30 ml per minute, we need not modify the doses. So you have to give the full dose abacavir lamivudine combination. So abacavir 600 OD plus that combination of abacavir 600 plus lamivudine 300. So that tablet we can give as it is. Now, if the creatinine clearance is less than 30, then we need to give as per the creat clearance, the calculated dose can come to either 150, 100 or 50 mg of lamivudine. Then we need to, ideally we need to have a separate abacavir tablet of 600, plain abacavir of 600, and then give a lamivudine tablet of say 100 mg OD or 150 mg OD or 50 mg OD. So that can be given as per the creatinine clearance. In that scenario, you can ask for your local SACs if they are providing the tablets, or they are reimbursing the patient with that. Sometimes some of the SACs are doing that they are buying the drug and giving to the patient. So that you will have to connect to your local SACs or DACs, whatever, and then ask for the drugs, because in MDACs in the Mumbai, these drugs are available through our ART centers. So that you have to ask for these different strengths to your local body. Otherwise, you have to prescribe it to the patient, and the patient may not be affording all this. I hope it is clear.
Thank you, ma'am. Any more questions from the participants? You are requested to please unmute your mic. Ma'am, there are no more questions. Thank you so much, ma'am. Thank you, Reshu, ma'am. Thank you, Puri, sir. Thank you, Revari, sir, for answering questions in the chat box. Thank you to all the participants for patient listening. We'll end the session now.
Thank you so much.
Sorry. Just wait for the post-test. Extremely sorry. Thank you, ma'am. Kiran, can we have the post-test, please? Participants are requested to please attempt the post-test questions. There are 5 questions in all. The first 4 questions are single choice answers, and the 5th question is a multiple choice answer. Please scroll through the questions and answer all the 5 questions. Participants are requested to please quickly go through the post-test. Kiran sir, we can end the e-poll now. We can have the feedback questionnaire, please. The feedback question is not now visible on your screen. There are 4 questions in all. Please scroll through the questions and answer all the questions. Kiran sir, we can end the feedback e-poll now. Kindly note, the next session will be conducted on Tuesday, that's 19th July, and the topic is ART treatment failure in adults and adolescents. We can close the session now. Thank you.
Answer.